My name is Werner Pichler, and sorry, I will speak in English, not in French, but I hope you understand it. Also, my English is quite tinted with my Tyrolean background. Nevertheless, thank you very much that we can organize this meeting of ADR-AC together with a Gaia group here in Geneva. And I will make a short introduction into this quite difficult topic, mainly discussing the classification of drug hypersensitivity, and briefly discuss with you why is diagnosis of drug hypersensitivity so difficult. There are different reasons. Once, because the clinic is very heterogeneous, many drugs, and each ADR, adverse drug reaction, is rare for each drug, but also because we have many false concepts in drug hypersensitivity. And because we have false concepts, we don't understand it. And therefore, I will briefly discuss with you the mechanism. And what I would like to emphasize is that the lability of drug-protein interaction is very crucial to understand why it is so difficult to diagnose. It's not very fixed, and it's a very labile binding what we have, what leads to our drug hypersensitivity reactions, and therefore it is not so easy to reproduce. And because it is so labile, you have a lot of cofactors which influence it. And when the cofactors disappeared, you don't have it anymore. And then at the end, I will briefly discuss with you ADRAC. ADRAC is a very special company, not only because it is founded by me, but because it's really devoted to interaction with the physicians. We would like to offer what we can to better diagnose, because drug hypersensitivity is a passion of mine, and I would like that all of you become all passionate for drug hypersensitivity. So. I'm employed by ADRAC now, I sold it, but I'm still employed and consultant. So drug hypersensitivity reactions are reactions toward a drug. It can be a small molecule or a protein, which elicits an immune or inflammatory response. So not always we have an immune reaction. Often it is just an inflammatory response, and then we speak of pseudoallergy. But often it is also an immune response. And the picture can be extremely heterogeneous, and that makes it quite confusing for the clinician, especially if you are a pharmacologist, because then we call it bizarre. What we work with is as bizarre side effects. Symptoms range from mild to severe. We still have quite a few deaths each year because of drug hypersensitivity. Just to remember, for radio contrast media, 2 people die in Switzerland on radio contrast media anaphylaxis. It's just for one drug, a class of drug, of course. We have rash, anaphylaxis, serum sickness, Stevens-Johnson, stress, etc., etc. Now, this is all what you have to know about drug hypersensitivity. You have to consider how it starts. It's all about drug binding to proteins. Because these drugs, and I speak now only about small drugs, not about proteins, bind to proteins. That's a natural process. You know that. You learn it in pharmacology. Transport of drugs by binding to proteins. But now you have to ask, how is it binding and where does it bind? How means non-covalent versus covalent. Covalent means really tight binding, exchange of electrons. So it is very stable, not easy to take apart, resistant to processing, for example, and it's becoming a really new antigen. Can you see? So when it binds, it's becoming an antigen. And this is one part of drug hypersensitivity. And you know what? And that is one of the messages. It's a minor part. It's not important for systemic drug hypersensitivity reactions. It's important for contact dermatitis. But the minority of systemic reactions are not due to antigen formation. They are due to non-covalent label binding to proteins. Okay, if that happens, nothing happens. You don't realize it, you don't react to it. That happens all the time. Whenever you take a drug, you have this binding, label binding, it's processed, nothing. But now the second part, maybe it binds to a crucial receptor of the immune system. It can bind to the immune receptors. And immune receptors, some of these receptors are very sensitive if something is coming close to them. Even if a drug comes close to them, they react already. And then you have a problem. And these immune receptors, if it binds to immune receptors, then we develop drug hypersensitivity. The different forms, we come to that. Or it binds to other proteins, and that is most of the time not so relevant because that is not, if it didn't have already an immune reaction. So how and where does it bind? These are the questions to understand when you see a patient. And now, the classification which I propose together with Oliver Hausmann is actually very simple. You can have an immune reaction, it's an allergic reaction, drugs are small, they need to bind covalently, stably to proteins to form a new antigen. So they form a new antigen. And that is contact dermatitis, and that is drug hypersensitivity, part of drug hypersensitivity, but actually only a minor part. And some exanthema mainly together with viral infection. But the rest of side effects you encounter in vivo in your patients is not due to this part. It's always due to PI, the pharmacological interaction with immune receptors. That means it's an off-target activity of the drug with immune receptors. The drug binds not to the right receptor. It doesn't bind to the enzyme cyclooxygenase or somewhere else. It binds off-target to an immune receptor. And the immune receptors are HLA, T-cell receptors, and actually also preformed natural antibodies. And some of these antibodies react with cell-bound structures. Then, if you have a modification, then you have blood cell dyscrasia. But the rest of it is always T-cells reactions, because mainly it binds to T-cells or to the HLA, T-cell receptors, HLA. It's a non-covalent, reversible labile binding. And on this labile binding, it is our drug hypersensitivity reactions are based. It can lead to exanthems, DRESS, Stevens-Johnson, or blood cell dyscrasia when it's antibodies. And then you have the third group, very important, very hard to diagnose in vitro because it's not an immune reaction. It's pseudoallergy. It's actually that the drug happens to bind to receptors on inflammatory cells, in mast cells, neutrophils, eosinophils, basophils, and stimulates these cells somehow. And then you have effector mechanism without sensitization. And because you have no sensitization, our tests wouldn't help. Yeah, it's pseudoallergy. And then you can have urticaria, angioedema, anaphylaxis, bronchospasm. What you see is local reactions, contact dermatitis, and not common in systemic reaction. Why do you see it sometimes? Because normally when you take a drug, it is not an antigen, even if it binds to a protein covalently. It's just an antigen, but it's not immunogenic because it don't stimulate the immune system. You don't have cofactors, but the cofactors are provided sometimes by the viruses. And therefore you have the coincidence of virus infections and drug hypersensitivity, because the virus infections prime your body, activate your body, and then you have your modification in addition to the virus infection, and then you react to both viruses and to the drug. That is illustrate. Then you have the T-cell reactions with exanthema and so on. With regard to the cofactor hypothesis, just a very new slide. It just appeared today, I believe, in Allergy, but it's preprint at least. You can check it already. It's an antigen-presenting cell, and maybe I show it here. You have if you get amoxicillin, you haptenize your body. That means I can check in your body 3 hours, 4 hours after you have taken amoxicillin, then many of your proteins are modified. They carry now, they are amoxicilloyl. Yes, they are haptenized. But you don't make an allergy. In 95% of the cases, you don't make an allergy because you don't have co-stimulation. But if you have now a virus infection, where you have a lot of co-stimulation already. Do you see it? I don't see it anymore. Here it is. Yes, then you have a lot of co-stimulation expressed here with the CD80 molecules, and there are a lot of presentation. And now you add again the drug, and then you have both. You have co-stimulation and drug presentation and the virus stimulation, and then you make reactions to the drug and to the virus, like here, and then you have exanthema. So here, as shown below, here nothing. Where is it? Here nothing, just virus infection, and here virus infection and drug hypersensitivity. But what does it mean? It means that your reactivity is only there as long as you have the virus infection. If you don't have the virus infection anymore, it is disappeared. Now, what does it also mean for you? It means drug hypersensitivity is not very stable. It's a transient issue. It goes and comes and goes, depending very much on the state of your activation of your cells. And when your patient comes to you and says, I have had an exanthema, and you make tests, and you find out nothing, then you will say, no, you are not sensitized. Or you are skeptical, and you are a good allergologist, and you say, maybe it's still something. Because in contrast to many people who always tell you that provocation is the gold standard, I don't believe that provocation is the gold standard. The gold standard for you in diagnosis drug hypersensitivity is a combination of factors, of symptoms, of history, of experience with the drug, of cofactors, of in vitro tests, skin tests, and provocation tests. And the aim is a reliable label based on collaborations of physicians, allergologists, and laboratory. And what you see here, very important are the allergologists. Because they have to combine all the different factors. You know, or you can imagine that the patient had a viral infection. He tells you that he didn't feel before, and then therefore I took it, and I went to the doctor and he gave this. So he knows all the information. And this is very important for making the decision whether the patient is indeed allergic or not when he reacts to a drug. It's not just skin testing, it's not enough. Cofactors are very important. History is very important. Symptoms are very important. But provocation, when you provoke him without cofactors, is negative. And then he makes again a viral infection, and then he's positive again. And I tell you that because there were deaths. My predecessor in the Institute of Immunology, Alain Devec, lost a child with 11 years. She was negative in provocation test, and the child got amoxicillin at that time again, or penicillin, and died in a sudden death, anaphylaxis. And he told me, never trust a negative provocation test. Yes, and therefore, what I want to tell you, it's in your hands that you combine all these factors and then you decide. And now we have good help. You have these guys here who make the in vitro tests. And that is ADR-AC. And actually, I founded this company 2006 with my wife, and it is late. And when I got older, I thought I'd get rid of it. I still work, awful, but I'm working and analyze about it and biogroup later on. And the scope, quite idealistic scope, was very simple: improvement, clinical application, and diagnosis of cellular death. Because I'm an immunologist trained with with T cells, and I was always convinced that cellular tests are important, especially in drug hypersensitivity, but also in many other diseases, in autoimmunity, for example, in chronic urticaria, or in immune deficiency, of course, and COVID, etc. And we also do some consulting for pharmaceutical companies. We were quite successful previously and also after founding ADR-AC, and so I think that what we do normally is quite solid, I hope, and if you don't find it solid, just tell me. I will talk with my people. And what we do is actually cyto-LTT, drug-induced cytokine secretion with many different drugs, 400, 500, 350, are we more? 600. 600, it's an old slide. The basophil activation test, drug-induced basophil degranulation, at least 35 tests established based on prior positive tests. We do CU-PAT for evaluation of serum factors in patients with chronic urticaria and SARS-CoV-2 T cell tests. The particular issue is that actually we are the only laboratory who do these tests in Switzerland, and actually when you look around in Europe, we get actually requests from all over Europe sometimes. So it's not very common that you do these cellular tests in a routine lab. Of course, we do also serology. It's because it's very good backup, and it's very good to have contact with allergologists. And also, actually, some of these serologies are also quite interesting. Is it okay, Oli? Yes. And the philosophy of ADR-AC is a bit different from other companies. Cellular immune reactions are important, but cumbersome to perform. They are expensive. It's manual work. To make a cyto-LTT requires 65 ELISA tests. 65 for one result to get. It's not a cheap test for us. And therefore, it's also expensive for you. Sorry. But it's actually quite low. We are lowering the price, what we could ask, because we don't want to take your money out of the companies, we believe in it. And this is now a compromise where we can live, and you hopefully as well, or the insurance companies. Then the tests are on the border between diagnosis and research. Sorry that I skipped it. Yeah. They require explanations and that is also quite cumbersome. Each test you send to you is commented. Of course, you can ask for that because you pay a lot for the test, and we do a lot. And therefore, it's more or less becoming a way to become not the quantity, but the individual tests are important. It's adapted to the individual needs, and I believe what we do is not personalized medicine, but personalized laboratory. And of course, these are the contrast to big laboratories which don't do these tests. And why are we now here in Geneva? Because I emphasized the collaboration with allergology is very, very important. And you need us, and we need you to make a better diagnosis of drug hypersensitivity. And we are the country in the world which does the best drug hypersensitivity diagnosis in all of the world. You can't go anywhere else. Here in Switzerland, you get the best results. And we get patients sometimes from Australia to call us, and sometimes they come even to give blood and to have the analysis. So that's one part. And the second part, very important, we want you to understand the tests. When you, in future, beginning of January the 1st, get the results, you will get a lot of cytokine values. And if you don't know what granzyme B is, granulysin is, IL-5 is, IL-13 is, interferon gamma, etc., and what it means, then you have difficulties. We still provide you with explanation, but actually we would very much like that you understand it, what we are doing, and the results. And therefore, as the last one, it's an in vitro test, and we have limitations. We need the feedback from you that we can improve our tests. And when we work together, I think we make the drug hypersensitivity diagnosis even better as it already is. Thank you very much.